Welcome, everyone, to another edition of the Sports Medicine Update with yours truly, and of course, the man of the hour. He's Dr. Chad Prodromos. He's the president of Illinois Sports Medicine and Orthopedic Centers, medical director for the Foundation for Orthopedics and Regenerative Medicine. That's a 501c3 Illinois non-for-profit corporation. And of course, he is the editor-in-chief, the Anterior Cruciate Ligament, Basic Science, and Reconstruction. Doc, how are you?
I'm terrific, Jerry. How about you?
I'm doing fantastic. Episode number 3, season number 1. And it's always informative, insightful, and of course, if we do the right things and do the way you instruct us to do, it could be rewarding as well. How's this past week been for you?
It's been good. We've gotten much normal, back doing procedures again. So it's been good.
No, that's good. And for me, I've been okay as well, Doc. No injuries, no pain. Everything seems to be going pretty well as far as my physical health is concerned. So I think you're rubbing off on me a little bit.
Hey, well, Jerry, you're a great specimen. You take care of yourself, so it's a given.
Sounds good. Well, the one thing that's not too certain of a given is the return of sports. And every day we're inching closer and closer to getting back to somewhat of a new normalcy, as we've been saying over the past few weeks with the pandemic and COVID-19. And we heard that this past week that the WNBA have elected and decided to have a 22-game regular season and, of course, a shortened playoff to get things back underway. We know the National Football League are looking forward to getting back to the facilities. The Chicago Bears over at Hallis Hall in Lake Forest, and I believe July 19th is a scheduled date for facilities to open back up and allow the coaches and the players to get back, because I know most of them have been doing a lot of Zoom training. We've heard the NBA as far as trying to get that local bubble, so to speak, down in Florida at Disney World to get the teams in preparation for the postseason. Unfortunately, the Chicago Bulls won't be a part of that. And baseball, they continue to go back and forth regarding a shortened season for 2020. It was at 70 at one point. They were hoping to try to get 90 games in at one point. Now I understand it's at 60 as far as this podcast is concerned. And before we know it, because the clock is ticking, it may be all the way down to 50 games. But I say all that to say, how close are we to, getting back to normalcy with COVID-19? I guess there were Houston down in Texas, a college university, 10 players were diagnosed, tested positive COVID-19. Universities around the country are looking forward to try to get back to that normalcy. But how much of it is a concern regarding COVID-19 and these athletes in their respective sports catching it, Doc? Is it something that should be of concern?
The good news is that young, healthy people, young, healthy, lean people in particular, which most of these athletes are, tend to almost always get very mild cases of it. Now, I have to be careful. We all have to be careful going down that line of reasoning, because you don't want to be too casual, because there's always a chance that somebody young and healthy will get it and get a very bad case. There were some cases documented in kids, kind of a different issue with an autoimmune disease that might be related. So I'm not aware offhand of people who have had terrible cases. There might be some. I know soccer players in Europe have gotten back a little sooner. And I think if a young, healthy athlete gets it, and people are gonna get it, you can test and try to be careful. But there were just some reports today, so people are gonna get it.
Okay.
And hopefully there won't be terrible cases. And as I say, the good news is that, and we know now, everybody knows now, that comorbidities, that age, that other problems, obesity in people of all ages really make you susceptible. So, if we're lucky, as we get into it and there's occasional players test positive, hopefully nobody gets real sick. And of course, it's not just the players. There's the training staff. There's other people. There are ancillary people, even if you don't have fans. But given the health of the population, if everybody's careful, and I think everybody's being careful,
Right.
I think we've got a reasonable chance of getting through this okay.
So, Doc, some of this, I'm glad that you mentioned some of the training staff. You got, you have some TV people. It's going to be a small crew. There's no question about it. And you mentioned there aren't going to be any fans in the stands, but you still have those around the teams and the organization that are very vital in pulling off, a professional event, regardless if it's on the football field or basketball or baseball or even on the ice and hockey. From a medical perspective, because you're not in your facility, whether it's the hospital or personal practice or anything like that, for those doctors who are expected to go down there and be available for the team and the players, what type of steps and precautions are they expected to take to protect themselves as well as their staff while they're treating a player that may succumb to an injury or, God forbid, symptoms of COVID?
Yeah, it's kind of the standard protocols, and it depends a little bit what you're doing. So, for example, dentists have a little more concerns, and I wear a mask pretty much all the time, conventional mask.
Sure.
There's another level where you can wear a mask, like an ND95 mask, for example, and then a visor over it. That's what dentists do. I'm an orthopedic surgeon. By and large, if I'm wearing a mask and the player or the patient is wearing a mask, and we check temperatures on everybody who comes in, and of course people can't be coming in with symptoms, and just all the other things. And I think everybody, we scrub down our exam tables, doorknobs, all that kind of stuff. So if you just do the things that, well, I guess it's standard for medical offices, maybe not standard for everybody, but we scrub down everything before and after we see people. We're careful who we see. We wear masks. That's about all you can do. And it's generally pretty effective, I think. And, it's kind of an occupational hazard of being a physician. So there's some risk. I don't think it's terrible risk.
No, I mean, I think that's good. And I hope that it's not a big risk. And you did mention, I heard the report as well, that dentists, the dental field, that's the highest risk of, contracting and testing positive for COVID-19. Is that because of, everything that's being used? I went for a cleaning yesterday, as a matter of fact, and they had to adjust as far as the cleaning was concerned. One being where there's I don't want to call it a utensil or whatever, but there's like a nozzle water spray that normally they would spray in your mouth, and they'll keep the suction in there as well while they're doing the particular work. But because of COVID-19 and the spread of it, they didn't do that with me, and they were extra cautious. Why is it in the dental industry, in the dentistry field, that it's more, the risk is higher as opposed to what you do, or a doctor, say at Northwestern Memorial or whatever?
Yeah, and it's something I'm especially familiar with, because even though I'm an orthopedic surgeon, my wife, Marilyn, is a dentist. She's a TMJ specialist, so she just deals with the temporomandibular joint. She's not doing extractions and fillings and that sort of thing, but she still needs to examine the inside of a person's mouth to check their occlusion and other things. And as we're learning more and more, it's become clearer and clearer, and I think everybody knows this, that droplets from saliva and that sort of thing are how the disease spreads most. There's more recent evidence that surfaces are a less likely source than we thought that they were. But obviously coughing, droplets. So dentists, kind of by definition, deal with people whose mouths are open.
Sure.
And they're, and the dentist's faces, and of course the port of access, as is through the face, is close to their mouth. So it's just inherently a higher risk. Same would perhaps hold true for an ear, nose, and throat doctor.
Yeah, I would imagine so. I have a couple friends that's in the industry as well. One actually young dentist practicing on the north side of Chicago, and he's taken every steps and precautions, that are mandatory and expected of him. But they just recently started seeing patients as well. So I know a lot of people have been eager to get back into the dental chair. Even though people say they don't like going to the dentist because of the drilling and all of that, I know there are a lot of folks who are waiting to get, in that chair, to get their teeth taken care of. By the way, Doc, I do have my mask as well.
Oh, wow. That's a work of art.
Buckeye.
Yeah. There you go. The Ohio State University. It's a beautiful thing.
We're practicing our social distancing, so we're fine. But I do have my mask, and I actually have about 4 or 5 of them. I have one at home. I have a couple in the car. I have one at the radio station. So I make sure that I'm definitely protected and being cautious and being respectful of others' space. Speaking of space, as we talked about, the National Football League, these guys have been doing a lot of Zoom calls across the league, across the country, and here in the Chicagoland area, the Chicago Bears and the coaching staff, they finally say, hey, enough is enough. We're ready to, get to the facilities and start seeing some of these guys live action working out. And, let's get back to our new normalcy. And I believe the projected date is July 19th, that facilities will be available for coaches and players to finally get together and start working out regarding training camp and getting prepared for the 2020 regular campaign. What sort of things have you heard or seen or are aware of regarding players? Because I know it's been very difficult with them working out at home, not being able to get to the gym. What sort of things have you seen from a medical aspect regarding these players and training and working out? And is there any caution regarding injuries because it's not the proper workout that they've been accustomed to?
Yeah, definitely, Jerry. You're right on the money. Years ago, professional athletes used to have other jobs in the off season, and training camp was to get in shape. But as you know, these days, most athletes work out and stay in good shape year round. So most of them have had enforced periods of relative inactivity. And the problem with that is that when you get deconditioned, whether it's cardiovascular or weight training, the obvious urge is to get back to it and get to where you were. And you just have to be very aware to take it very slowly. We tell people that have started working out when they hadn't been that it takes people maybe a couple of weeks. So when you start working out, if you haven't worked out, what you should do, whether it's weight training, running, whatever, is start out really slow. Don't try to condition. You just are kind of signaling your body and say, hey, I'm back. I'm going to be doing this. And then your body adapts. It lays down new blood vessels. And if you give yourself a period of a week or two, not doing much, just kind of getting warmed up, a little more than that, then if you hit it a little harder, your body's better able to withstand it. And we've seen people, and we've gotten calls from professional athletes who have gotten back into it, and not to say it's necessarily because of the enforced time off, but who've, gotten some sprains and strains, little minor problems getting back into it. It's just, probably the most important thing I could say is when I was growing up, and it's been out there forever, no pain, no gain. And
right.
It's just the worst possible advice. Probably the biggest advance in sports medicine from the time when I was a kid to a young practitioner to now is just the idea that the most important thing that you can do is listen when your body talks. And, maybe if it's a playoff game or something and you're kind of sore, maybe you play through it and you recover in the off season. But in general, when your body sends you pain signals, it's doing it for a reason, and you're far better off to listen to it early. Don't take pain medicines, back off, let your body recover before you ramp it up.
But Doc, let me ask you this question, because for professional athletes, obviously they're at the the top of the hill, so to speak, when you talk about, conditioning and preparation, and particularly with the, football players, National Football League. As we know, you're not really in. There's two types of being in shape. One is being in tip-top physical condition, right, where you can perform at an excellent level. But the other part of being in shape when you talk about playing football is football shape, and your body has to feel a little bit of pain to get acclimated to the contact sport at the highest level in the National Football League. So as a professional athlete, and you say, listen to your body, how do you know when you're in tip-top shape as far as playing at that level is concerned, as opposed to being injured and trying to play through the pain? Can you explain that it's a fine line there, but can you kind of like break that down for the lay person? Because we all see our favorite heroes. Mine, of course, was Walter Payton. I wanted to be like him when I was a kid. So in working out, you think, okay, Walter, he took a lot of pain and, he continued to go. How do you draw the line between being in physical shape and fighting through pain or being injured?
So I'll tell you, you can kind of it's a great point. You can make a distinction. As I mentioned last time, there are more injuries that occur, I think, from conditioning than there is from the sport itself. And when you think about it, you condition a lot, you practice a lot relative to the number of games you play. So the biggest thing that you can do, and with all the hamstring strains and all that kind of stuff, is that it proliferated. It never used to be anything close to this decades ago. Is that when you're conditioning, if you're feeling sore, you just have to back off. There's a thing called DOMS. It stands for delayed onset muscle soreness. And so if you're working out and you haven't worked out for a while, you won't feel bad that day, maybe not even the next day, but 48, 72 hours later, you'll feel bad. Let it pass. And then when you go back to conditioning, you'll be okay. So I would say that during the conditioning, if you're feeling soreness in a tendon, typically we see it patellar tendonitis, Achilles tendonitis, or even over a muscle, your body will usually foreshadow you. And sometimes it's hard to tell. The Kevin Durant example is kind of an interesting one. Kevin Durant had a pain in his calf, and his medical staff looked at it, and the calf muscle, the gastrocnemius muscle, there's two of them, and they coalesce to form the Achilles tendon. And again, and I'll say this every time I talk about somebody like this, I have no inside information. If I had it, I couldn't divulge it. This is just what's out in public information. But
Sure.
So he had this calf strain, and they looked at it and said, it's the calf. It's not the Achilles. He's probably okay. And I mean, I agree. I'd have probably done the same thing. And then he came back and then, subsequently ruptured his Achilles. So it's part of the same muscle. And it's not something that I've commonly seen. Actually, the calf muscle has its own characteristic injury that usually stays there. The only reason I bring it up is just to say, so I think his was handled fine. I don't think it's anybody's fault. It's just saying you've really got to be vigilant, that if you feel a little something, and I'll tell you what I commonly see is people will come into me and they say, well, my knee's kind of sore, my shoulder's kind of sore doing bench presses, but once I get warmed up, it's fine. And I tell them, don't be deceived. That's your body. I'm not positive I even know the mechanism, maybe that you're making your own endorphins. But when you work out, you should feel fine. Now, again, we're talking about training, not games. You should feel fine from the first rep, because if not, what happens is you'll do 5 reps on the bench into your first set and you feel pain, it goes away. But then next workout, it'll be 8 reps, and then it'll be the second set. And that's your body talking to you. And if you're smart and you just do it gradually, you won't get injured. Now, you mentioned games and game shape. So, in games, especially in football, there's different kinds of injuries. What you get a lot in football are contusions. Contusions are bruises. That isn't the same kind of an injury that you get when you're training. When you're training, you get strains. A strain is an injury of a tendon or a muscle, occasionally a sprain, which is the same injury of a ligament. So if you're in a game and you get a contusion, you get a bruise, you ice it, maybe you can play through it, except even there. If you get a contusion, for example, thigh contusions are common in football. And I see football players, and they say, well, hey, I'm fine, doc, I can go. but we make sure they got a full range of motion of their knee. If they don't go, because you're going to mess yourself up. And it's always a distinction. What can you play through? Walter Payton, unbelievable. Walter Payton, everybody knows about the Hill. He was amazingly conditioned. Walter Payton, you may know, missed one game.
Right.
And he had a dislocated toe, and he was held out of that game, and he wanted to play through it. And maybe he could have. But it's mostly the conditioning at the front end. And I'll tell you, he was very flexible. There's a huge emphasis on flexibility now more than there was. And I will tell you that you have to be very careful when you stretch. There isn't much literature showing that stretching prevents injuries, but there is literature, particularly hamstrings, showing that it can cause them. And I see every few months, I see somebody coming in doing aggressive hamstring stretching and causing an injury. So, with all of this stuff, it just takes a tremendous amount of discipline, because you have to do it gradually. You can't miss time. If you miss time and try to make up for time and do it harder, that's when you tend to get hurt.
Yeah. Wow, that's very insightful. And so much has happened, Doc, over the past, 34 years as far as the medical field is concerned, because as you know, we go back years and we remember, you get a little bruise or, you get a little pain, and what would coach tell you? Just rub some dirt on it, tough it out, and, if you didn't do it, you were considered weak. But now with the advancement and the technology and just the education and the knowledge of the medicine and the medical field, we were doing a lot of things wrong back during that time. And I know that a lot of athletes are extra cautious and extra careful regarding their injuries. And it's interesting you mentioned Kevin Durant, because there was a lot of speculation and a lot of finger pointing going on, because when he suffered the injury during the playoffs a couple years back, it looked like, and we've all heard the story, that when you rupture your Achilles or whatever, it's like you feel like somebody kicked you, right?
Yeah.
Because of the snapping involved with it. And he turned around and looked behind him, but there was no one behind him, and he started limping. So from a lay person's the naked eye, it's almost immediately that you thought, hey, he had a ruptured Achilles, and of course we know the history. They said he came back, and he did come back, and then finally it was diagnosed.
As I said, I think everybody did everything right. It was kind of a teachable moment for me, because I'm in that situation. I was saying, wow, that's really interesting, because it probably was related, but it isn't anything that anybody could have known, and particularly fast twitch athletes. There's fast twitch and slow twitch muscle fibers, and it's just a genetic thing. So sprinters are born; they're not made.
Right.
And fast twitch athletes, and almost all those guys are generate more torque than slow twitch athletes. So they're more prone to get that problem. The other thing that I would say too, and not everybody perhaps agrees with me, but I feel very strongly that, I tell my athletes, I tell my patients that pain is your friend, so don't try to mask it. So non-steroidal anti-inflammatory drugs, they're Motrin, Advil, ibuprofen, naproxen, Celebrex, meloxicam, they're widely used, but we keep everybody off of them. I think I might have mentioned this in one of the other times. So my point is that if you get a pain from working out, don't take Motrin, don't take Advil, like I mentioned the other time. Just feel it and let it go away on its own. Because if you mask that pain, you're far likelier to damage yourself worse, and you won't be able to tell when you're persevering with your conditioning.
Yeah, that's a good point, Doc. But unfortunately, everyone has a different threshold as far as pain. Some people can tolerate a lot of pain. Others, the slightest twinge, and they're crumbling to the ground because of the pain. How do you balance it between those who can handle it and those who can't?
Well, I don't think so. If you're in a game and you're getting, I don't know, you're getting beaten up, and you get a bruise, you get a contusion. If it's not around the joint, some of those you can play through. I sit up and play through it. But I think that when you're dealing with a joint, which is what most of these things are. Maybe a rib contusion, maybe you can get a flak jacket, play through that some. But I think not taking pain medicines, and this has changed just dramatically in the 35 years I've been doing this. And I think everybody knows, way back when athletes were shot up with cortisone, they give it all butazolidine. It's a great anti-inflammatory used on horses, except it caused occasional fatal aplastic anemia, so it went away. But I mean, bute back when I was first starting out. So my answer is the pain is protective. So your doctor should be able to tell you if you've got, if you're doing bench presses and you feel pain in the front of your shoulder where your rotator cuff is,
right?
Don't push it. It isn't a question of sucking it up and doing it, because if you do that, it's gonna end badly. Now, again, if it's, and just do something else. We have all kinds of alternative conditioning things. Work on your lats, work on your back, leave your chest and shoulders alone a little bit. But I think that if you're feeling pain, and again, it's mostly with the conditioning, we think that adjusting the conditioning so that you're not beating yourself up allows you to do a lot more in the actual competition.
No, that makes sense. Thank you so very much, Dr. Chad Prodromos. Sports Medicine Update. It's a weekly podcast, folks. I love it. It's the first season, episode number 3, and it's always informative and insightful and of course, educational. And I do apply it to my everyday life. Not that I work out excessively, but I do apply everything that you share with us, Doc, to my everyday life. And I feel good. I feel great. Real quick, I want to ask you about an acronym I've been hearing over the past few weeks, and I'm sure those listening and watching may have heard of it as well. PRP. What is that? Can you explain it?
Yeah, PRP stands for platelet-rich plasma. Platelets in your blood, which are we know that they produce blood clotting, also have growth factors. And these growth factors help you heal. They're substances with long names, transforming growth factor beta, platelet-derived growth factor, other things. And they also have cytokines, which are sort of like hormones that decrease inflammation. More long names. They're interleukins. And it's a yin and a yang. Some of these make you sore. Some of them make you less sore. So there was a smart doctor in Germany named Peter Veiling who did some of the initial work on this, and there were some athletes. He called it Regenokine, and it's kind of the predecessor to PRP. And there were many high-profile athletes, Kobe Bryant, and there were various NFL players who went to Germany to get this. This goes back 10, 15 years. Anyway, subsequent research showed that you can take a small amount of blood, centrifuge it, isolate the platelets, activate them, and inject it. And it has been life-changing in my practice. As I've mentioned before, even though I'm a surgeon, I view surgery as only a last resort if all else fails. And so I got interested in PRP actually when I read about Kobe Bryant getting Regenokine a long time ago, and the late Kobe Bryant, and started doing it 10 years ago. Didn't know if it was the real deal or not, but it has been life-changing for me, and I'll be talking about it on other podcasts because I do it a lot, and it treats many things. Kneecap pain, which is the commonest thing that goes wrong with knees. We have tremendous success doing this. It's a simple injection. It's not covered by insurance, unfortunately, but it's not real expensive. It's similar to stem cell treatments. Works sort of the same way, but much less expensive. We do it a lot in athletes. I've had some people recently find me, professional athletes in town who had some issues coming back where we've used that. We use it for knee pain, rotator cuff pain, Achilles tendon, tennis elbow. And so it's extremely safe. We draw blood, spin it down, isolate the growth factors, inject them back. You can't have a reaction to it. It's your own tissue. It decreases inflammation, but in a beneficial way. Cortisone decreases inflammation, but kills tendon cells and kills cartilage cells. So I basically never use it. Occasionally, maybe okay. So I think it's a wonderful thing. We actually just are finishing up a big research paper of a clinical series in people with partial tears of their rotator cuff, who most of them had surgery recommended, and we treated them with this and had overall really good results. So yeah, so PRP, I think is a terrific thing that we don't do it in everybody, because oftentimes just training alterations get people better. But we use it a lot.
And what's the life expectancy of it? So with the cortisone shot, it varies in different individuals, different people. I know I've taken some cortisone shots over the years, and I'd have it, last up to, between 3 and 6 months before I have to have another one. Regarding this PRP, I mean, what's the longevity for it?
It's interesting. So cortisone studies have shown, you're right, people usually say 6 to 8 weeks. It can certainly last longer. And I think an occasional cortisone shot's probably okay. I don't do them myself, but multiple cortisone shots are just definitely bad, and I think everybody kind of knows that now. So the PRP, it's a very interesting question, and I could go on for an hour, and I won't. But I've done over 4,000 of them, all part of a prospective study through my foundation that you mentioned. So we have what I think is the best, or one of the very best databases by an orthopedic surgeon that exists. And the answer is that it's highly variable. I get older people where it's an alternative to joint replacement, and it'll usually last a year, maybe a little more, and we can repeat it. In the younger people, for example, patellar tendonitis, kneecap pain, those kinds of things, often when people get better, it doesn't come back. And we work with people to adjust their conditioning and their regimens to take good care of themselves. So when it works, and in our hands, it works overall about 80% of the time. Some problems well over 90, bone-on-bone arthritis about 50%. But when it works, it almost always works for at least a year. And again, in young, healthy people, because I have a bimodal population. I have young, healthy athletes. Right. And I just did one on a tendon problem of a professional athlete who I can't mention, but and I expect it to go away and stay gone. In older people, oftentimes it has to be repeated every year or two.
This is something that could work with arthritis as well?
Oh yeah, it's pretty amazing. We just had a big paper accepted. We actually combined it with stem cell treatment, but a large part of, I do a lot of sports medicine, and that's all I used to do. But largely because of the advent of biologics, PRP and stem cells, which we study, we do research on these things and have clinical studies. I've taken to treating a lot of older people as an alternative to joint replacement. And it doesn't work in everybody, and it works better in earlier cases. But we have remarkable results, not always, but often.
Wow, that's great. That's good to hear. I know there are a lot of people who probably will look more into it to learn more about it, and maybe even go the next step and start getting treatment for it as well. Dr. Chad Prodromos, a Sports Medicine Update, a weekly podcast. Before we let you go, again, always a pleasure and great to just chat with you about the insights, because there are a lot of weekend warriors out there who, they've been out on the golf course, they're getting out on the lakefront running and biking and playing tennis, whatever they can do. And we don't want them to sustain any injuries, but, that's part of exercising, working out in sports, and know that they get a lot of great information from you. Before we let you go, there's also another term that's been floating around that I've heard over the past few weeks, and this is this low-level laser therapy, light treatment or something. Can you elaborate on that and explain to us?
And it's a similar sort of a thing, and it's something that I read about. The pioneer of it was is a Dr. Michael Weber in Germany. He's not the only one, but he's one of the main people. And just as I read about PRP, and I didn't really know, is this the flavor of the month? Is it the real deal? So I read about that, didn't know. This is applying laser light to powering it below the levels at which it produces heat or pain or side effects. And it's picked up by the actually, there's some question as to how it works. One thing we think we know is it's picked up by the mitochondria, which are the part of your cell that produces energy and works on an enzyme called cytochrome C oxidase. It gets wonky, but anyway, it's not a heat thing. The light energy is picked up by cells and helps things to heal. And so again, I had read about it, didn't know it was a real deal. So I went to a conference actually in Germany that he gave to find out more, and then visited someone at the Mayo Clinic who did a lot of work with it, Peter Dorscher, a very smart man, and became convinced it was probably real. Started using it 5 years ago. And again, I could go on forever, and I'll do that in more detail another day. But suffice it to say, it's something where little skin diodes are put on your skin. There's no heat, no pain, no side effects. It's powered at a level where there's red and infrared light usually that are absorbed. We use it in back pain, neck pain. My wife uses it for the TMJ. There's other applications too. It's really an interesting technology, but it allows me to treat things, hamstring strains. It works remarkably well. Also not covered by insurance, but pretty inexpensive, maybe $50 a treatment. I have a physical therapist, Dr. Angelo Dazan. He's been with me for 17 years, terrific therapist, very bright guy. And I turn the patients over to him. He applies it. The results are usually immediate. And again, not in everybody. But actually, I've done this in some of the professional athletes too. I do it at an athlete, pro athlete who had a problem that I treated with PRP in a tendon, and he got better. Still had some soreness, and then he came in for laser treatment. It helped, and he comes in occasionally. So these are all newer things that really don't have a downside, and allow us to treat people without surgery, without cortisone and such.
That's great, Doc. And I bring a tear to my eye because I feel bad, Doc. I think I was ahead of my time, because if I had all this type of treatment when I was a young lad, jumping and running and doing all this activity, I'm certain I would have been destined to play in the professional ranks, any sport that I chose. But
I have no doubt.
Hey, Doc, it's always a pleasure. We come to an end. If anybody wants to find out more about sports injury, sports medicine, and of course, if they have any problems with shoulders, knees, ankles, how do they get a hold of you?
So our main number is the Burbs 847-699-6810, and just talk to anybody who answers. I've got a great and loyal staff that's been with me a long time. And then our website is ismoc.net, so Illinois Sports Medicine and Orthopedic Center.net, and an email it's just ortho at ismoc.net will get to us as well.
Dr. Chad Prodromos, President, Illinois Sports Medicine and Orthopedic Centers, thank you so very much. It's another edition of the Sports Medicine Update, the weekly podcast. Hey, take care of yourself. Have a healthy weekend, and we'll talk to you next week.
You too, Jerry. Take care.